1. Hiatal hernias and GERD. 2. Functional motility disorders. 3. Acute traumatic injuries. And 4. Barrett's esophagus and neoplasms. Starting off with Section 1. Hiatal hernias and GERD. What actually happens when the anatomical boundaries between the stomach and esophagus just fail? So it's all about the gastroesophageal or GE junction. Now, type 1 is your classic sliding hernia, which is mostly tied to reflux, but types 2, 3, and 4, totally different beasts. Here, the junction stays anchored, but the stomach or even other abdominal organs literally herniate right up into the chest. And the major clinical takeaway you've got to remember? These increase the risk of gastric volvulus and ischemic ulcers. They frequently need surgical repair to prevent absolute catastrophes. When you look at a barium swallow for a massive type 3 combination hernia, it's pretty wild. A huge chunk of the stomach has pushed up into the chest, taking both the greater curvature and the GE junction right along with it. Imagine the sheer space that takes up in the thorax. It perfectly explains why these patients come in complaining of breathlessness and early satiety. When that much stomach is sitting above the diaphragm, it completely wreaks havoc on normal digestion and breathing. Now, if all this leads to persistent GERD, the text outlines a very strict protocol. You start with behavioral tweaks and proton pump inhibitors. But if medical therapy fails, or the patient just doesn't want to be on meds forever, we look at surgery. But hold on, before operating, you absolutely have to verify the reflux with 24-hour pH testing. That is the gold standard. And you must do esophageal manometry to rule out underlying motility disorders. That step is crucial because it changes your entire surgical approach. Speaking of surgery, we have to contrast the classic 360-degree Nissen wrap with the 270-degree two-pet wrap. The Nissen is incredibly effective, sure, but it carries a higher risk of post-op dysphagia and gas bloat syndrome. So if your pre-op manometry showed abnormal esophageal motility, you go with the two-pet wrap. It's a partial posterior wrap that strikes the perfect balance, stopping the reflux while maintaining actual esophageal transit. All right, moving on to Section 2, Functional Disorders and Strictures. Let's see what happens when the esophagus loses its normal neuromotor coordination. Achalasia is the most common primary motility disorder. The defining feature here is a complete loss of effective esophageal body peristalsis, plus a lower esophageal sphincter that just refuses to relax when you swallow. Pathologically, this all goes back to alterations in the ganglia of the Auerbach plexus. This neuromotor failure creates that classic bird's beak taper on a barium swallow, simply because the unrelaxed sphincter causes the esophagus above it to dilate more and more over time. So, thinking back to the clinical presentation, what is the single most common presenting symptom of achalasia? We're talking something seen in practically 100% of these patients. It's progressive dysphagia to solid foods. This is absolutely key for your differential diagnosis. Progressive dysphagia strictly separates achalasia from other spastic disorders, like nutcracker esophagus. Those primarily present with severe spastic chest pain that can honestly mimic a heart attack. Achalasia, on the other hand, consistently gives you that hallmark swallowing difficulty. Pivoting now to Section 3, Traumatic esophageal injuries. We're talking life-threatening acute emergencies. 20%, that is the devastating mortality rate of an esophageal perforation. This is a dire, ticking clock emergency, most commonly caused by intraluminal instrumentation injuries. If you miss this, leaked esophageal contents rapidly flood the mediastinum, triggering a fast and often fatal plunge into overwhelming sepsis. So if you spot pneumomediastinum on a CT or a leak on a water-soluble contrast study, you have to execute these stabilizing steps immediately. Priority 1, adequately drain the leak. Then, hit them with broad-spectrum IV antibiotics, aggressive fluid resuscitation, keep them strictly NPO, and set up enteric diversion past the leak. These initial moves are absolutely non-negotiable to gain control of the sepsis before you even think about definitive operative repair. Another massive trauma, caustic ingestion. Think liquid alkali drain cleaners causing severe coagulation necrosis. The absolute golden rule here is never ever induce vomiting. Doing that just exposes the already burned mucosa to the chemical a second time. No way. Instead, you secure the airway, aggressively resuscitate, keep them NPO, and carefully evaluate the damage with gentle esophagoscopy. Finally, we hit Section 4, Barrett's esophagus and neoplasms. Time to talk chronic cellular changes and cancer progression. 50 to 100. That's how much the risk for developing adenocarcinoma multiplies once a patient develops Barrett's esophagus. That's the intestinal type metaplasia. Now, sure, the absolute risk per year for a single patient is still relatively small, but a multiplier that huge, it means we have to watch these patients like hawks. It's a glaring cellular warning sign. Looking at the management algorithm from the text, everything hinges on the histology, specifically the presence of dysplasia. No dysplasia? Just stick to periodic surveillance. Low-grade dysplasia? You tighten those surveillance intervals. But if you see high-grade dysplasia, which the text notes is functionally indistinguishable from carcinoma in situ, you escalate logically and immediately. We're talking definitive interventions like endoscopic mucosal resection, radiofrequency ablation, or even a full esophagectomy to stop the progression cold. When frank malignancy does occur, you absolutely must differentiate the two primary types of esophageal cancer. Squamous cell carcinoma favors the middle third of the esophagus, is strongly associated with African American race, and is heavily driven by alcohol and tobacco. Contrast that with adenocarcinoma, which now actually makes up the majority of U.S. cases. That one strikes the distal third and is tightly linked to white race, obesity, and of course, chronic GERD leading to Barrett's. So given these genuinely grim outcomes, we're looking at a baseline 5-year survival rate of just 20% for resectable cases, plus highly complex TNM staging. How do we actually outsmart this devastating disease? What is our best clinical weapon? The answer is early detection. Strict endoscopic surveillance of high-risk GERD patients is literally our most powerful tool to improve survival rates. Catching metaplasia before it turns into high-grade dysplasia is how we save lives. But as AI diagnostics and screening tech get better and better, you have to wonder, how soon will we be able to predict and entirely reverse these cellular changes before dysplasia even has a chance to begin?